Hello, and thank you for joining us today. My name is Lauren Edgar, and I come to you from the Southern Nevada Black Nurse Association in partnership with Pfizer. Today, we'll be sharing with you specifics regarding geographic origins, diagnoses, and treatment of hereditary amyloidosis in African Americans. Thank you for joining us. Next slide. Specifics regarding the Southern Nevada Black Nurse Association. We bring to you information regarding amyloidosis as a way to advocate for Black healthcare consumers as we look to serve as change agents and continuously serve the national nursing body to influence legislation and policies. I'll pass it to you, Dr. Tracy Johnson Glover.
Thank you, Lauren. So a little background. As we all know, there's a lack of diversity in clinical research, and especially in genomic medicine research. About 78% of data used in genome-wide association studies comes from people of European descent, even though this group only makes up about 16% of the global population. And so there is a lack of diversity in that research. This lack of representation has resulted in a lack of data that could foster a greater understanding about gene-disease relationships within a diverse African-American community. hATTR amyloidosis is an important use case to highlight the importance of African-American community engagement in genomic medicine research, which is why we're bringing this presentation to you. The SNVNA went on a mission to engage African-American nursing professionals in discussions about genomic medicine research, and the goal to identify and characterize their concerns about engagement and participation in research. And now I will hand this back over to Dr. Rachel Hendricks-Sturbuck.
Thank you very much. My name is Dr. Rachel Hendricks-Sturbuck, and I am a former researcher at Harvard Pilgrim Healthcare Institute, where a large part of my work involved collaborating with the Southern Nevada Black Nurses Association. Where there, we collaborated to engage members across all chapters, really, of the National Black Nurses Association, engaging them to take a deeper dive into understanding their concerns about themselves engaging, and also patients that they serve of African-American descent engaging in genomic medicine research, or what we also like to call precision medicine research. And we learned quite a few things, and also came up with a list of actionable strategies to encourage patients and also African-American nurses to overcome concerns that they hold about engaging in this type of research, considering extensive history in this community and the concerns that have ensued thereof, the history that has led to resistance in engaging in this type of research or clinical research in general. So we are on a mission to continue to educate the African-American nursing community and the African-American community in general about the importance of engaging in genomic medicine research. Starting with today, the use case of hereditary amyloidosis. Just so you all aware, this slide is a picture of a paper that we published recently in the AMA Journal of Ethics entitled African American Nurses' Perspectives on Genomic Medicine Research. It is an open access paper, and we encourage all of you to have a look on the AMA Journal of Ethics website. Right now, we are going to share with you a story of a patient named Cece. She shared her story with the Amyloidosis Research Consortium, basically her journey through having symptoms of amyloidosis, and then going through the diagnostic odyssey and journey of actually being diagnosed and ultimately receiving treatment. Here's her story that we'll share with you all today. Well, thank you all for taking time to listen to Cece's story and journey towards becoming diagnosed with hereditary amyloidosis. Now it's my pleasure to introduce you to our presenters, Dr. Kayur Shah and Michelle Kittleson. They are going to present today two topics. Dr. Kayur Shah will present on the V142I hereditary transthyretin amyloidosis, a disease of Black Americans. And Dr. Kittleson will present on diagnosis and treatment of transthyretin amyloid cardiomyopathy. Thank you both for being with us today to engage our NBNA members on this topic. I will go ahead and stop sharing my screen and turn it over to our presenters.
Thank you so much, Dr. Hendricks Stirrup. I'm just going to share my screen here. And well, I'd like to thank the Southern Nevada Association of Nurses for inviting me and my colleague to speak on this very interesting topic that's very near and dear to my heart. I'm only sad we're doing it virtually and not from sunny Las Vegas, but maybe next year. My part of the bargain here is to discuss V142I, or also known as V122I, hereditary amyloidosis, which really in the United States is a disease that predominantly affects Black Americans. Now, anytime we discuss amyloidosis, I think it's fair and probably responsible to define what we're talking about. Often to providers, nurses, and patients alike, the concept of amyloidosis is confusing. And when we talk about amyloidosis, we're really discussing a protein disease, a disease of protein misfolding. And the word amyloidogenic, at least in an online dictionary, is defined as something that tends to produce amyloid deposits. Okay. And these amyloid deposits are difficult to reabsorb by the body, they're resilient, and they deposit in organs, causing dysfunction and destruction. In the heart, when these proteins deposit, and here is an autopsy of an unfortunate patient of mine from many years ago, the deposits cause thickening of the heart walls. They lead to a restrictive and stiff heart. The patients develop heart failure, shortness of breath, swelling, fluid retention. Eventually, many of them have conduction disease, need pacemakers, may have atrial fibrillation. And this disease tends to be progressive. On the biopsy sample on the right, what you see is the pink are normal heart cells or myocytes. And in between them, there is this amorphous material, these rivers of pink protein deposits that are disrupting the normal cells and eventually lead to fibrosis, stiffening of the heart, and the pathology I showed you on the left side of the screen. There are many different proteins that can become amyloidogenic, but today we're going to discuss the transthyretin protein, or TTR. In all of us, TTR is a naturally circulating protein. It's what we call a homotetramer, or it's made of 4 identical monomers, and it functions as a transporter. It's also known as prealbumin. What happens in TTR amyloidosis is this protein, which has a normal function in our bodies, becomes dissociated and unstable. This can be because of mutations in the protein, or it can be related to aging and stress. Eventually, the unfolded proteins turn into what are called protofibrils and then mature fibrils. And it's these mature fibrils that compose these devastating amyloid deposits that cause a variety of symptoms and a progressive and sometimes fatal disease. Now, while Dr. Kittlestein is going to talk about diagnosis, and disease pathology a little bit more. I'm going to focus on a specific mutation that causes a hereditary variant of TTR amyloidosis, and then I'm going to go through a variety of diagnostic clues that you may or may not see in patients and in clinic that should raise concern of amyloidosis. So the V142I mutation, also known as V122I, was first discovered during an autopsy study of an elderly African-American man who was thought to have wild type or senile cardiac amyloidosis. On examination of this patient and genetic evaluation of the tissue, they found an isoleucine for valine exchange at the 122I position. And so this patient with this mutation in the protein died with extensive amyloid deposition, or this proteinaceous material in the heart. And at that time, it was the first time this genetic mutation was associated with amyloidosis. It was initially called a V122I mutation, and later they included 20 additional amino acids in the opening codon sequence and renamed it officially V142I. So you'll see this referenced in the literature and on genetic testing reports as both V122I and V142I. They're both the same mutation. It wasn't long after that case report that many more reports started to arise that were associating this mutation in Black Americans, almost exclusively. Without going into details of several of these reports, ultimately, it was discovered that about 1 in 4 to 1 in 5 Black Americans carries this mutation, okay? And if you carried the mutation on autopsy studies like this, it increased the likelihood that you developed amyloidosis in the heart. Now, why, at least in the United States, does this genetic mutation predominantly affect Blacks? Well, it goes back to the slave trade. These are genetic studies from different countries in Africa. And what you see on this heat map on the right of the screen is increased intensity in Western Africa. And it's from this area, increased intensity of the mutation. And in fact, in some of these countries in West Africa, the prevalence of the mutation is identical to that of the United States. And it's hypothesized that during the slave trade, that many of the patients we see today genetically originated from this part of Africa and populated the Caribbean countries and the Eastern United States. In present day, in clinical practice, and I'm going to have you focus on the pie graph on the right, the predominant cause of hereditary amyloidosis seen in the United States is this mutation. So, unlike previous data, for example, the Tau study performed at referring centers where patients who had access to this care were referred to centers that have expertise in amyloidosis, or classically described as having expertise in amyloidosis, such as the Mayo Clinic or Boston University, Columbia University. This mutation composed of nearly 40 to 50% of patients with hereditary amyloid. In older studies, predominantly in Europe, this was a minor cause of hereditary amyloidosis. The point I try to make here is in the United States, in clinical practices that see cardiology patients who may or may not have this disease, hereditary amyloidosis is predominantly a cardiovascular disease that affects elderly Black Americans. This was a very nice paper put together by Ahmad Mashri and some of his mentees that summarizes from different centers across the US what the prevalence of the mutation is, and these are the blue boxes, in genetic sampling in Black Americans, where anywhere between 3 and 4% are carriers of this mutation. And then also in the pink boxes, what percentage of the hereditary patients seen at these different programs have this mutation. Again, the point here is the V142I or V122I mutation is carried by a high number of Black Americans in the United States. Doesn't necessarily mean they have disease. They're carriers of this mutation. And in the US, the idea of discussing hereditary amyloidosis is not really a disease of a polyneuropathy, as it's classically been studied and described in literature, but it's a disease that causes heart disease and congestive heart failure in Black Americans. Now, I mentioned that many Black Americans carry the mutation. How many actually develop disease? And this is an area of active research. What we do know is what increases is the risk of congestive heart failure if you carry the mutation, and it increases with age. So as you start reaching your 50s and 60s, the odds of having heart failure is increased if you're a mutation carrier. And if you are lucky enough to make it to age 80, it's almost certain that you will develop some deposition in the heart, and it's not clear if it's going to cause heart failure or not. So right now, being a monogenic carrier of the mutation, it's not clear if you're going to actually develop amyloidosis and clinical heart failure, but your risk of it is at least double and increases with time. The groups that are at highest risk are men, those with a history of hypertension, and with increasing age. So the next point here is carriers of the mutation are at increased risk of developing heart failure. It doesn't necessarily have to be classic amyloidosis, which I'll show you in a few images coming up. And the penetrance of the mutation itself, if you're a carrier, is unknown. But what we do know when we discuss the topic of cardiac amyloidosis is compared to other types of transthyretin amyloidosis, and those would include wild type, which is aging-related amyloidosis that affects people as they reach their 70s and 80s, and looks very much like this, but can affect anyone of any race. And also other mutations which cause cardiac amyloidosis. The V142I mutation has the poorest survival, where from the time of diagnosis in recent studies, the survival is thought to be about 2.5 years. This is compared to 5 to 7 years for other types of TTR amyloidosis. So in addition to being a highly prevalent mutation in about 1 in 20 Black Americans, in addition to increasing the risk of heart failure and affecting predominantly the elderly, it is also associated with the poorest survival. So it's the most aggressive type of cardiac amyloidosis caused by the transthyretin protein. And lastly, to the points brought up in the introduction, despite all of these facts of being the most prevalent and the most aggressive form of hereditary TTR amyloidosis, it has some of the lowest representation in clinical trials for studying drugs for treating this disease. In this day and age, and Dr. Kittelson will go into this a little bit more about the mechanisms of these drugs and evolving therapies. In this day and age where only one FDA-approved treatment is available for this drug and many don't have access because of cost, we have very poor representation in clinical trials from Black patients to see if these new therapies are efficacious in this more aggressive type of amyloid. Now, I'm going to spend the second half of my talk trying to give pointers to this audience about when to suspect amyloidosis. So we're talking about diagnostic clues. Many of these are related to cardiovascular imaging, but some of these also may be helpful for those of you not in the cardiac field to consider when you're just treating patients with other medical issues. So me being a cardiologist, some of my clinical clues and red flags really come from our bread and butter testing, one of those being echocardiography or ultrasound of the heart. Classically, in these patients, we'll see thickening of the heart walls. Patients may develop heart failure with preserved ejection fraction. These patients may have small cavities because the hearts have gotten thick. And if you look at this echocardiogram image here in the middle of the screen, you see a very thick intraventricular septum, the wall between the right and left ventricle. This heart is almost maybe misdiagnosed as someone that might have hypertensive heart disease or hypertrophic cardiomyopathy. The atria can or are sometimes dilated. If this is more long-standing, they may or may not have a small pericardial effusion. But really, there might be some specific findings that are that some centers perform on echocardiography, but in general, it is often, or at least early on, misdiagnosed as someone with just having left ventricular hypertrophy. In addition to echocardiography, on electrocardiography, on your EKG, there may be some clues. One is the patient's voltage may be decreased, and this occurs as this proteinaceous material replaces the myocytes or cells of the heart. And the myocytes are through which the conduction occurs prior to contraction and generates the deflections on the EKG. So it dampens the tracing. So patients may have low voltage on the EKG. This is not a very specific finding. It's a nice, it's an interesting finding when it's there, but many patients with amyloidosis, if you're waiting for them to develop low voltage, you'll miss the diagnosis until it's too late. In addition to that, patients may have something called a pseudo-infarction pattern. That's the presence of Q waves, which classically describes someone who's had a heart attack in that region of the heart, but the presence of Q waves and the absence of a history of a heart attack. This is an EKG from a patient I took care of in fellowship who had TTR amyloidosis, and it was a hereditary variant. It's a famous baseball player who went on and unfortunately passed away from advanced heart failure. In that day and age, and I'm a little bit older now, but in that day and age, we knew very little about hereditary amyloidosis. The family wished to keep the diagnosis private because it was hereditary in nature. It was unclear what stigma would be associated with it. And in the newspapers, he was reportedly to have died of a heart attack. That being said, today, and with presentations and talks like these and awareness that's increasing in the community, especially as we have a better understanding of this disease in the Black community, I think people have been more forthcoming, and there's been great advocacy to increase awareness and improve treatments for this disease. I'm not going to spend too much time on some of the advanced clues, but as cardiologists, when we look at these echocardiograms, what helps distinguish it from things like hypertrophic cardiomyopathy or hypertensive heart disease are distinct patterns of wall motion. We call this, this is a polar map that can be made when measuring global longitudinal strain on echocardiography. And we often call this a cherry on top pattern. So the top row are patients with amyloidosis, and the red in the middle suggest better wall motion at the apex. And we just, in our lingo, we describe this as relative apical sparing of wall motion. And this distinguishes high amyloid patients from people with other causes of thickening of the heart, and that being hypertensive and hypertrophic heart disease. And what's really helped diagnose this illness has been advancements in MRI technology. And MRI offers high resolution images of the heart and techniques that can help us find deposits in the heart, including using contrast and different mapping techniques to identify fibrosis in the heart. So again, just showing some images, not going to go into too many details here on the technical aspects. So these are some of the clinical clues, again, highlighting in red the ones that are a little more specific that we see on imaging, electrocardiography, and MRI. Some of the things we see in clinic, now, often we find these after we suspect amyloidosis, but have been going on for years, are some peculiar physical exam findings. These are pictures from 2 of my patients that I see in clinic that I'd been embarrassingly following for a couple of years before I noticed this. And I only noticed it when we were enrolling them into clinical trials. And I was manually doing the EKG on them. And what we have here is a Popeye sign in 2 patients. They're flexing their biceps. And these are not bodybuilders. These are 80-year-old men with TTR amyloid who've had rupture of their biceps tendon. And so when trying to flex their arm, it certainly looks like they're Popeye. And this occurs sometimes many years before they're diagnosed with cardiac amyloid because of amyloid deposition on the biceps tendon. And if you have a patient who's got thickening of their heart and it's a history of biceps tendon rupture, it's very likely they have TTR amyloidosis rather than other causes of thick heart cardiomyopathy. And this column is hypertrophic cardiomyopathy or Fabry's. So again, a prevalence of biceps tendon rupture in a patient with a thick heart is highly suspicious of a patient having cardiac amyloidosis. Another finding, which has shown more and more specificity for identifying patients with cardiac amyloidosis or even predict that someone will develop cardiac amyloidosis, is the presence of carpal tunnel syndrome. In addition to depositing in the heart, the TTR amyloid deposits tend to go to the carpal tunnels and cause a compressive neuropathy. In fact, the presence of bilateral carpal tunnel syndrome can predate the diagnosis of cardiac amyloidosis anywhere between 5 and 15 years. And so if somebody has a history of bilateral carpal tunnel syndrome and starts developing cardiovascular symptoms, be it arrhythmias, heart failure, exercise intolerance, or thickening of the heart on imaging, an evaluation for cardiac amyloidosis should be pursued. So again, some clinical clues are related to heart failure and exam findings related to congestion and right-sided heart failure. I'm not going to go into these, but these are available for reference for anybody that would like to read more about it. But some specific findings that were not necessarily cardiovascular related, at least historically, include carpal tunnel syndrome, biceps tendon rupture, and one I didn't talk about was lumbar spinal stenosis, which is a little less specific, but also can be related to amyloid deposition in the spine. Now, there's so much more to talk about, but we do have limited time, and I'm going to pass the baton on here to my colleague and amyloid expert, Dr. Michelle Kittleston from Cedars-Sinai University. Let me just click the right buttons here. And I think I did this correctly. There you go, Michelle. Thank you very much.
Okay, so now we start the mental status portion of the talk where we figure out if I know how to share my slides. Okay, hang on. I'm going to do this, share screen, and then I'm going to pick my presentation, which should be this one, slideshow, PowerPoint slideshow. Okay, dun, dun, dun. You should be able to see my first slide. Not if you can see it. Yay. Okay, very good. So delighted to be here. Dr. Shah gave us such a fantastic overview. Some of what I'm going to say is a little bit not redundant, let's just say reinforcing. I'm going to hit some of the important highlights of the diagnosis and treatment of transthyretin cardiac amyloidosis. So overview, cardiac amyloidosis, protein infiltrates into the myocardium, resulting in a restrictive cardiomyopathy. 2 most common places the protein can come from, and this is important to know what else can it be besides TTR that factors into your diagnostic algorithm. The 2 places it can come from, light chains, that's called the AL amyloid cardiomyopathy, or of course the TTR protein, which is ATTR cardiomyopathy. And it's Dr. Shah so nicely outlined that TTR protein has one of 2 sources, either a mutation in the gene or wild type. And as he said, this protein can not just infiltrate the heart, it infiltrates other places too. And the other places it infiltrates can give you clinical clues to the diagnosis. So think the nerves, neuropathy, the kidneys, particularly in AL and nephropathy, gastrointestinal involvement in all forms, and the orthopedic issues. And we know that the earlier you identify it, the better it is for the patient. And I love this figure that goes through the clinical progression of cardiac amyloidosis. And you can see that the infiltrates start quite early, but it's not until later in the disease course when patients actually start to get a fall in their ejection fraction or a decline in their renal function or hospitalizations. So how do you know, how do you have a high index of suspicion? So to summarize a lot of what Dr. Shah put forth, the heart failure symptoms are the tip of the iceberg. But if you have a patient who has a lot of other seemingly disparate signs and symptoms, you can have your alarm bells, your clinical gestalt start to go off and say, wait a minute, maybe there is a unifying diagnosis for these seemingly disparate findings, which could include fatigue, other cardiac issues, atrial fibrillation, conduction system disease. Interestingly, in case series, about 15% of patients who present with aortic stenosis or heart failure with preserved ejection fraction actually have underlying cardiac amyloidosis. And remember that increased LV wall thickness. The echo report might say LVH, left ventricular hypertrophy, but don't write it off to hypertrophy of the muscle. Think about an infiltrative process as well. The neurologic, the sensory neuropathies, autonomic dysfunction, one big clinical clue. You try to give a vasodilator to treat their blood pressure and their blood pressure plummets. Something funny is going on. And then the orthopedic symptoms like the carpal tunnel, the spinal stenosis. So say you do a great job, you look for these clinical clues, you have that clinical suspicion based on the history, the ECG, the echo that something funny is going on. The thing about cardiac amyloidosis is you're not going to diagnose it on routine testing. You have to order specific tests to get to the diagnosis. And so what are the 3 plus or minus 1 tests that will lead you to one of the 3 possible diagnoses? So first, a monoclonal light chain screen. Remember, AL, light chain cardiac amyloidosis, needs to be excluded. So you look for monoclonal light chains. Then, if you find them, you have now destined the patient to get a biopsy, because you can't diagnose the AL form, which is on the spectrum of multiple myeloma, a plasma cell dyscrasia. You can't diagnose it without a biopsy, and you don't want to miss it because the treatments are diametrically opposed to that of TTR, transthyretin amyloidosis. So monoclonal light chains plus minus a biopsy if positive. If they're negative, then you will do a technetium pyrophosphate scan, a nuclear medicine study, which has been an amazing advance in the management of patients with amyloidosis, because it means if you've excluded the light chains and you're looking for TTR, you can actually diagnose it without a biopsy. Non-invasive diagnosis is possible. And then if you find that the technetium scan is positive, you have to do genetic testing, because as we just heard, that it's very important to figure out if the patient has the variant, the mutation form, or the wild type. There's implications for offspring, there's implications for therapy and prognosis. So a few subtleties about this diagnostic algorithm. First, we all memorized in school that if you're looking for monoclonal light chains, you should do an SPEP and a UPEP. Actually, not true. The SPEP, UPEP are not as sensitive as IFE, immunofixation electrophoresis. So when you're doing your light chain screen, don't stop at the SPEP, UPEP, order the IFE. You don't want to miss the light chains. Second, we all memorized you're doing a biopsy for amyloid, do a fat pad. Not true. Fat pad's not sensitive. You need to biopsy the affected organ, the heart or the kidney. And finally, if there's only one thing you remember from everything I'm saying, remember this. The technetium pyrophosphate scan is diagnostic only if the light chains are negative. You will do your patient a disservice if you order the scan without also ordering the light chains, because if there's a positive scan which can happen sometimes with AL, and you don't diagnose AL cardiomyopathy, you're robbing them of the right treatment for their disease. So always order your technetium scan in the context of your monoclonal light chain screen. So as Dr. Shah mentioned, there's a spectrum of mutations. Some cause more neurologic features, some cause more cardiac features. The ones we think about most are the ones I've circled here. And as he mentioned, V122I, V142I is where it's at. 3.4% of African Americans has cardiac involvement when symptomatic with rare neurologic involvement. So that's the one to really know the most about. And then just a few studies about our experience with amyloidosis in African American patients. Let's start with this study from about 10 years ago, which compared outcomes of patients with the variant form of transthyretin cardiac amyloidosis from the V122I mutation. All were African American because, as Dr. Shah mentioned, that's where this mutation occurs, compared with wild type, non-mutated. Greater mortality, greater hospitalizations in those patients with the variant form, the V122I mutation. So was this worse prognosis related to the fact that these are African American Black patients versus white, or is it something about the biology of the variant mutant form versus the wild type form? So a study hot off the press helps us to answer this question. So this is a study that just came out in the Journal of Cardiac Failure about a week ago. And what this study does is it compares all patients with the V122I mutation. And interestingly, there was a group of Black Americans, and they found a separate cohort of patients with the same mutation who happened to be white living in Italy. So they compared outcomes, clinical characteristics, all with the same mutation, Black versus white. And they found that Black patients compared to white patients had lower systolic blood pressure and pulse pressure at diagnosis, reduced renal function, smaller left ventricular size, lower stroke work as measured by echo parameters. So what does this mean? Does this mean that even with the same mutation, there's an interaction between genetics, race, and environment, so Black patients have worse disease? Or were the Black patients just diagnosed later in the course of the disease? So I was honored to actually write the editorial for this article hot off the press. And what my take-home message is this is a step in the right direction of the kind of studies we need to untangle biology versus disparity in the racial differences in cardiac amyloidosis. So stay tuned, there should be more studies down the pike to help us answer these questions. Now let's move on to therapies for transthyretin amyloidosis. So if you think about the pathophysiology guides therapy. So what could you do if you don't like this TTR protein that's depositing into the heart muscle? Well, you could suppress the production. You could do a liver transplant because the liver makes it, or you could give these gene silencers that are mRNA analogs that prevent the translation of these proteins. You could do TTR stabilization, where the TTR is there, but you don't allow the fibrils to form that will deposit in the heart muscle. Or you could have some resorption, where you can take the TTR out of the heart muscle. Well, don't get too excited about that option because that actually is not ready for prime time. And let's talk more about stabilization versus suppression or silencers. So tafamidis is a TTR stabilizer. It prevents further deposition of the amyloid fibrils into the heart muscle. And it's really the best we've got. So the ATTRACT trial, 400 plus patients, tafamidis versus placebo, a 13% absolute reduction in mortality. That's huge. And also a reduction in heart failure hospitalizations. The study came out in September 2018. By May 2019, the FDA had approved tafamidis. So really, this is standard of care for patients with diagnosed symptomatic TTR cardiac amyloidosis, and subgroup analysis indicates it works better if you're less symptomatic which stands to reason because it halts progression, it doesn't reverse disease. Diflunisal is another stabilizer, not impressive. To summarize these trials, there's only one randomized trial, the rest are open label or retrospective, and what we see is it's overall not well tolerated. About 50% of patients stop it because of its NSAID fluid retention properties, and there's no established impact on cardiovascular endpoints. In this day and age, it cannot be considered standard of care. There's a newer stabilizer on the block, acoramidis, studied in the ATTRibute-CM trial. In this trial, they had two endpoints. One was 6-minute walk test, and the other was mortality and cardiovascular hospitalization. Of course, mortality and cardiovascular hospitalization is what we care about more. The top line results of the 6-minute walk test results just came out last month, and we found that it did not impact 6-minute walk distance after being on therapy for 12 months. Are we discouraged? No, we are not discouraged. We are patiently awaiting the 30-month mortality and cardiovascular hospitalization endpoint to get a sense of how this medication works. So those are the stabilizers. What about these gene silencers that would stop production of TTR? Well, there are two on the market, patisiran and inotersen, both in randomized trials of patients with the variant form and neuropathy, showed to improve or halt progression of neuropathy. There are some post hoc analyses or open label studies that show in cardiomyopathy, there's a reduction in some surrogate endpoints like LV strain, thickness, BNP. We were all really, really excited about the Endeavor trial, which was finally going to test a silencer in cardiomyopathy, but it was stopped early due to increased deaths in the treatment arm. Whether coincidence or causal, we'll never know. So we are now still awaiting patiently future studies of these silencers in patients with TTR amyloid cardiomyopathy. And the two I am most interested in are CardioTransform and HELIOS-B because they have real endpoints of death and cardiovascular hospitalization, study completion dates 2024 and 2025. So when we put it all together, when you confirm the diagnosis, you may treat their heart failure, you may treat their arrhythmias, and when it comes to disease modifying agents, if they got wild type cardiomyopathy, tafamidis, if they got the variant form cardiomyopathy, tafamidis, if there is neuropathy, these silencers are also an option. And in the next few years, we'll figure out where to put these other agents in the treatment algorithm. So what do we know? We know that ATTR cardiomyopathy is more common than you think, so have a high index of suspicion in the face of clinical clues. We know that tafamidis is the only effective evidence-based therapy. And what do we need to know? We need to know if silencers will work in TTR cardiomyopathy. We need to know if acoramidis will work. We need to know if the standard of care will become a stabilizer plus a silencer. To know what happens when we get too good at the diagnosis. How do we manage asymptomatic patients? And a discussion of the treatment of cardiac amyloidosis would not be complete unless we also mention the elephant in the room, which is money. These therapies are priced astronomically, hundreds of thousands of dollars per year. And we have to also advocate for our patients in the face of this financial toxicity. And remember that it's not just great science that saves lives, but the proper equation is great science plus effective implementation equals lives saved. So thank you for your attention. And now I will attempt to return the host properties to Dr. Hendrick-Stirrup. All right.
Thank you so much to you
Take host.
both. Awesome. Wonderful. Thank you so much. Dr. Kayer Shaw joins us as Chief of Heart Failure at the Virginia Commonwealth University Hospital. Dr. Michelle Kittleson joins us from Smith Institute at Cedars-Sinai. Thank you both so much for these incredibly and thoughtful and enriching presentations. I, for one, have learned so much, and I very much look forward to moving into our next segment, which is asking you all questions. Bear with me one second as I get my slides together, if Zoom likes me, that is right now. One moment. All right. So we will go ahead and move into our Q&A. So I, for one, took a lot of notes. I can literally sit with you all day long and ask you questions, but we can't do that right now. And you guys have a lot of important things to do. And I'm sure my colleagues, Dr. Tracy Johnson-Glover and Lauren Edgar, also have a lot of questions as well, and lots of interest in this topic, obviously. So I do want to kick off our Q&A with just one question. Both of you talked a lot about, the need to further understand the asymptomatic features, or rather what can be done at the asymptomatic phases of this disease, especially in African Americans who carry the 142I mutation and thus have a higher likelihood of experiencing heart failure later in age. So what are your thoughts and ideas around, especially as genetic testing might play a role in this, and as we engage our NBNA members in genomic medicine research, what are your thoughts and ideas around what could be done early on in the clinic to identify patients who are at greatest risk of heart failure and other symptoms that you've so eloquently described and identified for the audience today?
Michelle, if it's okay, I'll share a few comments and then hand it over to you. There's many million-dollar questions that Dr. Kittleson brought up, and this is definitely one of them. So as we're discovering and identifying patients with this very prevalent mutation, we're also finding family members who have not reached that later age, who may have had carpal tunnel syndrome or have just discovered they're a carrier of this mutation. And then as we educate them, we describe to them that not everyone develops disease. It's just increased risk, but it's not certain doom. And then we're here stuck with one approved therapy by the FDA, which is one of the most expensive medications ever approved. And they're wondering what to do. They feel like a ticking time bomb. We're walking them back. So for these patients in clinic, we kind of all have our own wonky surveillance program, and mine is very similar to how I treat hypertrophic cardiomyopathy family members, is periodic imaging, annual visits for symptoms and an EKG, periodic biomarkers, maybe a baseline nuclear scan at some point if it's going to be approved. But I also delve into the realm of off-label considerations and some of the things that Michelle had on our slides, such as green tea supplements, turmeric, other things such as, combining vitamin C with a green tea supplement. And there are some prescription medications, which at least in the laboratory and in small studies may be beneficial if you have established amyloid. She mentioned diflunisol. Some people believe in doxycycline and a bile acid sequestrant. There are these piles of medications, some which are over-the-counter supplements that are being studied, but we don't know if they work, that can prevent amyloid deposition or promote fibril breakdown, and some which are prescription medications, which may have some side effects and cost to them. Sometimes I dip into these, but otherwise it's a lot of reassurance and assurance that we'll be watching them closely. And reminding them that, the best we know right now is most patients who have it actually don't develop cardiac amyloidosis. The risk is increased, but they don't develop disease. Michelle, I'm sure you have some wise words to add.
Oh yes, I'll do my best to be as wise as possible. You know, it's such a tough area. It's always hard for me when our ability to measure things outstrips our ability to understand the significance and the relevance of the measurement, right? So, you know, there's actually a clinical trial going on right now, an observational study called SCAN-NP, where they're taking Black and Hispanic individuals and doing screening with bone scintigraphy, nuclear technetium type scans to see what's the overall prevalence of identifiable TTR amyloid involvement. And I think that'll be really interesting to offer insight into what you know, as Dr. Shah said, 3.4% of the population may have it, but what is the symptomatic relevance? So and I think it also often comes down when it's a data-free zone like this to what kind of style of medicine you practice. Are you more of a do everything, or are you more of a do very little? And I tend to err on the minimalist side. And so if I have a patient with a proven mutation, V142I, I will say, I'm really glad we found this because there's implications for therapy down the line should you develop neuropathy. And it's also very useful because your offspring now, they know they have a heightened awareness, they're at risk. And I say whether or not they need to be tested, I think is a big discussion. It's not oh, you have it, they should get tested. Because what are the implications of knowing you have this gene, which may never be a problem or may turn into a problem? And I have seen offspring who are asymptomatic gene carriers who their life is turned upside down with the stress of this diagnosis. Now, granted, they're probably have the personality to be more worried, but this doesn't help. And then you see on the part of the parents who now have this incredible guilt that they pass this on to their kids, so many unintended consequences, and what's the benefit? So I really think this is such an important area to understand more about, and I almost counsel against testing of asymptomatic offspring at this point, since we don't know what to do with the information, but a heightened awareness that if you start to get symptoms, gosh, you're just a little more fatigued. What? You've now got this carpal tunnel. You have, at least your clinicians who are caring for you have a better sense of how to direct the diagnostic algorithm instead of having the years-long delay in diagnosis that happens to people generally with amyloidosis.
To piggyback on some of those points, you know, the field has been thinking about this question for a while, and there was an interventional clinical trial that was designed and almost ready to go that's on hold right now that was going to look at acoramidis in pre-disease patients. So if you were a gene carrier and you had either had carpal tunnel syndrome or you were over the age, I believe, of 55, you could be eligible for this study, where they would treat you with drug or placebo, and then you would get frequent PYP scans. And this was to better understand disease progression on and off treatment in pre-symptomatic patients. Unfortunately, that study's on hold until the Attribute CM trial is complete and we learn more about the long-term efficacy of this drug.
Awesome. Thank you so much. Lots to think about. And, you know, like I said, I have so many questions there, but I can easily take up all of the time that we have. I'm going to go ahead and pass it to Dr. Tracy Johnson Glover, who has a question for you as well.
Yes. So I have just two questions, and either one of you can answer them because you both addressed this. One is, what other organs do you see this in? We're talking about the heart, we're talking about the liver. Have you seen this in lungs? Have you seen this in other major organs? And the second question is, you explained, Dr. Shah, about, you know, the green tea and the supplements. Why, Dr. Kittleson, did you kind of take that off?
I'll start with that, and then you know, I've reviewed some of the data for some guideline writing work I was doing, really taking a deep dive into green tea, TUDCA, doxycycline. And as Dr. Shah said, it's really a lot of animal models or preclinical studies. And it kind of depends, I guess, is the glass half full or is it half empty? Do you
Yeah.
think I've got some surrogate endpoint stuff, so how can it hurt? Or do you think every pill is another pill and I don't want to give something unless I know it works? There's no right answer. This boils down ultimately to the art of medicine. And I would let Dr. Shah take care of me or any of my family members because he's extraordinary. It's just kind of just a difference in style. I don't think he's right or wrong. I don't think I'm right or wrong. I don't think anyone knows the right answer.
Okay. And well, one other question before you go. Why do we take off liver transplant?
Oh yeah,
Is it because it's so invasive or?
It's very interesting that back in the olden days when you could have severe cardiac involvement from TTR amyloidosis, the treatment in some centers, standard of care was not a heart transplant, but a heart liver transplant, particularly in people who had very severe neuropathy, because that neuropathy could be debilitating, not just the sensory neuropathy, but such significant autonomic neuropathy that patients would stand up and their systolic would go to 60 and they were essentially bedbound and unable to conduct a normal life. So in those patients, even though you'd fix the heart that was going to kill them, the neuropathy would give them such terrible, unacceptable quality of life, you do a heart liver. That has fallen out of favor recently, one, because it's scarce and precious use of organs, but more importantly, not only a scarce and precious use of organs, but we don't think we need it now in the era of stabilizers and silencers. So if you fix the heart, can you control the extra cardiac disease with stabilizers and silencers? Also a data-free zone, but something we have used, at least in our program, is when patients have a lot of neuropathy after heart transplant, we are embracing patisiran for that indication, hoping that we can control their and maintain their quality of life now that we know that the heart failure won't kill them.
So, and just a few points to add to what Michelle's saying is, keep in mind that hereditary TTR amyloidosis is a very heterogeneous disease. If you think back to that slide she showed with all the mutations, and on one side you had people with severe neuropathies, and on the other, you had our V122I or V142I patients. So the liver transplant, the experience and the data from there, a lot of it comes from Europe, where some of these other mutations have dominated over the years. And they tend to be more rare here in the US, but still prevalent, but much less common than the V122I. So when we talk about hereditary TTR amyloid here in the United States, you're talking mostly cardiologists. And in Europe, it's a much more multidisciplinary approach. Furthermore, the multi-organ involvement that Michelle had on our slide is you tend to see less intense systemic disease in these V122I variants, but you see more systemic disease in all of those others, very debilitating mutations. So right when you had clusters of families in Europe that's you knew grandpa had it, dad had it, and you start having those early neuropathy symptoms in you or your siblings, that's when they would talk about performing a liver transplant to cure the disease and stop progression, because it was a terrible course with some of these early Val30 MET mutations and some of the other European variants, where 30 and 40-year-old patients could develop severe neuropathies in 3 or 4 years, be bedbound, and soon die. And so liver transplant was very appealing was billed as a cure in that population.
Thank you. We are almost at time, and I do want to close out with, I guess, just one final question that's quite broad. Going back to our goal and aim to engage National Black Nurses Association members in genomic medicine research and also educate their patients about the importance of it, what would you say is the single most important takeaway for these members to know, given everything that we've talked about engagement in TTR stabilizer and silencer research, genetic testing, components that might accompany that? What is the single most important takeaway from both of your perspectives for this particular audience?
All right. For me, and my messaging in my amyloid outreach and just an evaluation of patients and talking to other physicians, it is really still a message of awareness, of not, as a patient, not being pigeonholed, and as a provider, keeping your differential broad when you approach a Black patient with a thick heart and heart failure. It's not always hypertension. It's not always medical comorbidities. Do not stop thinking about it there. Look a little further. There's another disease pathology that is prevalent and it's treated differently, and you could harm your patients if you don't look further and treat them as you always have for a hypertensive patient or other cause of thick heart disease.
Oh, I love that one. Okay, so I have one too, which is when you do what Dr. Shah says, and you have that heightened awareness and you put together the clinical clues and you delve deeper, remember that when you order your technetium pyrophosphate scan, you must always order a monoclonal light chain screen, because you do your patient a terrible disservice if you miss the diagnosis of AL cardiomyopathy in a patient who you're looking for amyloidosis. Always order the two together.
Wonderful. Thank you so much. And again, Dr. Kader Shah joins us as Chief of Heart Failure at the Virginia Commonwealth University Hospital. Dr. Michelle Kittleson joins us from SMID Heart Institute, Cedars-Sinai. So I will go ahead and pass it over to Ms. Lauren Egger, who will close out our session. My last slide here provides everyone with our contact email addresses. Thank you so much for joining us. And without further ado, Lauren, feel free to close us out.
Thank you so much, Dr. Thank you to you all. Thank you, Dr. Shaw. Thank you, Dr. Kittleson. And thank you, Dr. Johnson Glover. On behalf of Southern Nevada Black Nurse Association and the Greater National Black Nurse Association, and of course, Pfizer, thank you so much for your time today. I really hope that you enjoyed this educational series. I believe on behalf of advocating for the Black community, not just in Southern Nevada, but all around the world, it is very important to make sure that we stay close to what our body listens to. And I really think that it is important for us as clinicians to take heed to what Dr. Shaw and Dr. Kittleson had to share. Thank you again. Again, our contact information is on the slide you see before you. And I hope you have a safe year. Take care, everyone.